Assalamu alaikum. Today I would like to discuss about multiple renal disease in short. First of all, hydronephrotic kidney. Hydronephrosis means dilatation. Hydronephrosis means dilatation of the pelvis and calyces. Dilatation of pelvis and calyces. What happens in here that in hydronephrosis, first of all you have to know that the most important cause, one important cause is urinary tract obstruction. Urinary tract obstruction by the tumor or congenitally or some stone which may obstruct the urinary tract. It may be due to BPH. Severe BPH can obstruct the urinary tract, and if there is injury to ureter. These are the cause of urinary tract obstruction. And other cause is retroperitoneal fibrosis, and other causes include one important cause is VUR, that means vesicoureteral reflux. VUR, vesicoureteral reflux. In here, serum creatinine is elevated if there is obstruction occurs bilaterally. If there and if the person has solitary kidney, and obstruction occur in only that single kidney. So that is the reason uh, of having hydronephrosis. It leads to compression of the compression and possible atrophy of the renal cortex and medulla. Okay, this is the histological picture of RCC, that means renal cell carcinoma. In renal cell carcinoma, there is a flank pain. In renal cell carcinoma, there is 3P, that means palpable renal mass, pain in the flank, and painless hematuria. If you found these three features, that palpable renal mass, pain in the flank, and painless hematuria, and the age of that person is above 40, above 50, and at that time you have to think that the person might have renal cell carcinoma. It actually originates in the PCT, proximal convoluted tubule. It invades the renal vein. And may develop left-sided varicocele. In here, there may be development of left-sided varicocele, and it metastasize. This renal cell carcinoma metastasize hematogenous route. Can you tell other cancer that spread via hematogenously? There are 4 cancer. One is this, another renal cell carcinoma, another one is hepatocellular carcinoma, then choriocarcinoma, and last follicular carcinoma of the thyroid. It's the most common renal malignancy, most common in 50 to 70 years of old, and increased incidence in obesity and smoking. And you know that in this type of cancer there is a chance of developing paraneoplastic syndrome. And in here, the paraneoplastic syndrome can be remembered by this mnemonic PEAR, that means parathyroid hormone related peptide, erythropoietin lipoproduction, ACTH, and renin. In this renin causes hypertension, this ACTH causes Cushing, this EPO causing reactive polycythemia. The reactive polycythemia and parathyroid hormone related peptide actually increases calcium. And in RCC there is 3 word, so the chromosome should be chromosome number 3. And in here you have to remember that in RCC, renal cell carcinoma, you have to do surgery and immunotherapy. You have to do surgery and you can give immunotherapy, but there is no chemotherapy and radiation therapy, because in here chemotherapy and radiation therapy are resistance. That's why the in the pipeline of the treatment you have to do surgery and immunotherapy. And in immunotherapy you can give that, leukin. In immunotherapy you can give the aldesleukin or targeted metastatic aldesleukin. This is the pipeline. This is the drug used in renal cell carcinoma. Another thing in here, the histological picture show polygonal clear cell. This is the polygonal clear cell filled with lipids and carbohydrates. Polygonal clear cell filled with lipids and carbohydrate, and often golden yellow due to increased lipid content. It is often golden yellow due to increased lipid content. This is all about renal cell carcinoma. This is a picture of oncocytoma. Renal This is picture renal oncocytoma. In renal oncocytoma, there is benign epithelial tumor arising in the collecting duct. Can you remember that renal cell carcinoma happened where? It happens in the renal cell carcinoma RCC happened in PCT, but in renal oncocytoma happens in the collecting duct. It happens in the collecting duct. In here there is large, this is oncocytoma, there is large eosinophilic cells with abundant mitochondria without perinuclear clearing. In here there is large eosinophilic cell with abundant mitochondria with perinuclear clearing. Perinuclear clearing. It has to be differentiated versus chromophobe renal cell carcinoma. It presents as painless hematuria, flank pain, and pain in the and palpable renal and palpable abdominal mass often resected to exclude malignancy like renal cell carcinoma. Now this is the picture of schistosomiasis, bilharziasis, schistosoma infection in the bladder called bilharziasis, and it causes squamous cell carcinoma of the bladder. These schistosoma hematobium infection can cause squamous cell carcinoma of the bladder. Okay, in squamous cell carcinoma of bladder, it usually causes chronic irritation in the urinary bladder, so there is squamous metaplasia. There is chronic irritation there is chronic irritation of the bladder and it causes squamous metaplasia. This is IL. In there is squamous metaplasia and then dysplasia and can cause squamous cell carcinoma. And the risk factor include these one: schistosoma hematobium infection, and other causes include chronic cystitis and smoking, chronic nephrolithiasis and cystitis. It also presents with painless hematuria. Next, a picture. First, I would like to talk about transitional cell carcinoma. Then I would like to discuss about other carcinoma. In transitional carcinoma, also known as urothelial carcinoma. Transitional carcinoma, also known as urothelial carcinoma. Sorry, I lost the picture of the transitional carcinoma, but I can discuss about transitional carcinoma. In transitional carcinoma, what happens in transitional carcinoma? It occurs in the renal calyces. Pelvis, ureter, and bladder. Renal calyces, pelvis, ureter, and bladder. Transitional carcinoma happens in renal pelvis, calyces, ureter, and bladder. Renal pelvis, calyces, ureter, and bladder. It also presents with painless hematuria, and the mnemonic of remembering the cause is PSAC. That PSAC is phenacetin, smoking, aniline dye. Aniline dye is used in different chemical factory. Aniline dye and cyclophosphamide. Can you remember the side effect of cyclophosphamide? It may cause hemorrhagic cystitis, and in that particular time you have to give to protect your cyst or protect your bladder for having hemorrhagic cystitis. At that particular time you have to give injection mesna. Okay. So what are the cause of this transitional cell carcinoma? The transitional cell carcinoma happens in renal pelvis, calyces, ureter, and bladder. Renal pelvis, calyces, ureter, bladder. Pelvis, calyces, ureter, bladder. And the mnemonic is PSAC, that is phenacetin, and smoking, aniline dye, and cyclophosphamide. Can you remember the cause of the squamous cell carcinoma of the bladder? Yes, in squamous cell carcinoma of the bladder, first cause is this one, schistosomiasis, and the other cause is chronic cystitis and pyelonephritis, smoking. Okay, now this is acute pyelonephritis. In acute pyelonephritis, it easily affects the cortex. This chronic pyelonephritis actually happens in the cortex, sparing the glomeruli or vessels. Okay. It presents with fever, flank pain, that means postovertebral angle tenderness, and nausea, vomiting, chills. The causes include that ascending UTI is one of the important cause of this pyelonephritis, and it may spread hematogenously, and you may get WBC casts in urine because there is and in here, as it is acute, so there is neutrophilic infiltrate. in the renal interstitium. This is the neutrophilic infiltrate of the, this is the neutrophil, this is the neutrophilic infiltrate of the renal interstitium. The risk factor include indwelling urinary catheter, urinary tract obstruction, viewer diabetes, pregnancy, viewer diabetes, pregnancy, viewer diabetes, pregnancy. Can you remember the risk factor again? Indwelling urinary catheter, urinary tract obstruction, vesicular reflux, and diabetes mellitus and pregnancy. And it, from acute pyelonephritis, it may, as a complication, can convert into chronic pyelonephritis, renal papillary necrosis, perinephric abscess, and urosepsis. And as it is an infection, you should give antibiotic. And in next picture is chronic pyelonephritis. And what happens in chronic pyelonephritis, that is, uh, it is the result if a person having acute pyelonephritis, and if you don't treat him promptly, at that time he or she may develop chronic pyelonephritis. Typically occur predisposition infections such as VUR and chronic obstructed kidney stone. VUR and chronic obstructed kidney stone, chronic obstructed kidney stone. Okay, in here these tubules contain eosinophilic cast resembling thyroid tissue. This is the high thing. You have to remember that in a chronic pyelonephritis there is thyroidization of kidney. Thyroidization of kidney. What does it mean? In thyroid, that means tubule contain eosinophilic cast resembling thyroid tissue. In here, this tubule contains eosinophilic cast that resemble, tubule can contain eosinophilic cast resembling thyroid tissue, and this is called thyroidization of the kidney. This is high end. You have to remember it. And other thing you have to remember, in chronic pyelonephritis there may be granulomatous pyelonephritis, xanthogranulomatous pyelonephritis. This is a rare infection usually caused by this proteus, and it a grossly orange nodule that mimic tumor nodule. It is grossly orange nodule that can mimic tumor nodule. So you have to figure it out that that if you think that this is tumor, so you have to exclude this xanthogranulomatous pyelonephritis. Okay, now this is the picture of autosomal dominant chronic kidney disease, ADPKD, and this is the picture. This is the ultrasonogram of ARPKD, and this is another picture of ARPKD, autosomal recessive polycystic kidney disease. In autosomal dominant, first autosomal dominant polycystic kidney disease, what happens in here? There is numerous cysts in the cortex and the medulla. It also presents with flank pain, hematuria, hypertension, urinary tract infection, and multiple PKD1 85%, and PKD2 is 15%. PKD1 is 85%, and chromosome number 16, and PKD2 is 15%, and chromosome number is 4. You have to remember the chromosome number 2. And the other thing you have to remember that the complication includes a Berry aneurysm. Complication include Berry aneurysm, mitral valve prolapse, benign hepatic cyst, and diverticulosis. Benign hepatic cyst and diverticulosis. And that's all about PKD. Autosomal dominant polycystic kidney disease. In autosomal dominant polycystic kidney disease, it is a association or complication. Association is it may be in here there may be development of airway aneurysm, there may be mitral valve prolapse, autosomal mitral valve prolapse, mitral valve prolapse, benign hepatic cyst, and diabetic mellitus. If hypertension and proteinuria develops, treat with AC or ARB. In ARPKD, like in here, ARPKD, there is cystic dilatation of the collecting duct. There is cystic dilatation of the collecting duct. There is cystic dilatation of the collecting duct, and in here, there it causes tuberointerstitial fibrosis and progressive renal insufficiency with inability to concentrate urine. Medullary cysts usually not visualized, and smaller kidney on ultrasonogram, Okay, and other thing in autosomal recessive polycystic kidney disease, you have to remember that it may cause congenital hepatic fibrosis. There may be Potter sequence. There may be progressive renal insufficiency, portal hypertension, and fibrosis. This is the complication of ARPKD. That congenital, it may cause fibrosis, hepatic fibrosis, and it may cause portal hypertension, progressive renal insufficiency, and systemic hypertension. And another thing you have to remember that this is nephroblastoma, also called Wilms tumor. Nephroblastoma, also known as Wilms tumor. In Wilms tumor, it usually happens in early childhood, 2 to 4 years of old. 2 to 4 years of old. It contains embryonic glomerular arteries. It presents with palpable unilateral flank mass, hematuria, and possible hypertension. There may be WT1 and WT2 mutation, and in nephroblastoma there is three disease: Weger syndrome, WAGR, Weger syndrome. In Weger syndrome, there is Wilms tumor, there is aniridia, there is growth retardation. Wilms tumor, there is Wilms tumor, aniridia, and genitourinary malformation and mental retardation. Genitourinary malformation and mental retardation. In mental retardation, and due to disability in WT1 deletion. Can you remember the Weger syndrome? Yes. In Weger syndrome, there is Wilms tumor, aniridia, genitourinary abnormalities, and retardation, mental retardation, and it may be due to WTA1 deletion. In Danish-Drash syndrome, in Danish-Drash syndrome, what happens in Danish-Drash syndrome? There is Wilms tumor. There is dysgenesis of the gonad. There is Wilms tumor. There is dysgenesis of the gonads. There is diffuse mesangial. There is diffuse mesangial sclerosis. There is diffuse mesangial sclerosis. There is diffuse mesangial sclerosis. And the last but not the least, that Beckwith-Wiedemann syndrome. And Beckwith-Wiedemann syndrome, in here there is again Wilms tumor. In here there is again Wilms tumor, and there is macroglossia. There is organomegaly, and there is hemihyperplasia. And the last thing I want to discuss About the urinary incontinence, this is high yield urinary incontinence. In urinary incontinence, there is stress incontinence, there is urge incontinence, there is overflow incontinence. Stress incontinence, the cause is urethral hypermobility or intrinsic sphincter deficiency. Urethral hypermobility or urethral hypermobility, urethral hypermobility or urethral hypermobility or in intrinsic sphincter deficiency. Intrinsic sphincter deficiency. It may be leak with increased intra-abdominal pressure, like in obesity, in vaginal delivery, like in the risk factor is obesity, vaginal delivery, prostate surgery, and of the and you can do bladder test which is positive. You can do bladder test which is positive. Bladder stress test is positive, and as a treatment, you can do pelvic muscle strengthening exercise, pelvic muscle light liberator and iron strengthening exercise, casual exercise, weight loss, and pressures. Casual exercise, weight loss, and pressures. And in urge incontinence, there is detrusor overactivity. Detrusor overactivity. There is detrusor overactivity. In urge incontinence, there is detrusor overactivity, which is associated with UTI. Detrusor overactivity, and as a treatment you can give oxybutynine for overactive bladder, urge incontinence, overactive bladder. You can give oxybutynine, but in here PVR post-vital residue is normal. In urge incontinence, there is detrusor overactivity, leak with urge to void immediately. Association with UTI, you can do that casual exercise, bladder training, and as a drug you can give oxybutynine. And the last is overflow incontinence. In overflow incontinence, there is detrusor underactivity. Detrusor underactivity or outlet obstruction. Detrusor underactivity or outlet obstruction. Detrusor underactivity or outlet obstruction. It leak with overfilling, associated with diabetes, BPH, and MS. Diabetes, BPH, and MS. In here, PVR is more. In overflow incontinence, PVR is more. On catheterization, treatment include catheterization, relieve obstruction, or with the help of alpha blocker. And the last disease I want to discuss about the cystitis. Cystitis is inflammation of the urinary bladder, is called cystitis. It may present with frequency, urgency, nocturia, and in here the systemic signs like high fever, chills are absent. High fever, chills, and absent. Fever and chills are absent in acute cystitis. The most important organism is E. coli, Staph saprophyticus, Klebsiella, and Proteus. A gram-negative organism, Klebsiella, and the Proteus mirabilis. In Proteus mirabilis, there is urea has ammonia scent. Lab findings include positive leukocyte esterase, positive nitrites indicate gram-negative organism, and there is sterile pyruvate, that means passing the urine but no growth in the culture suggests that urethritis by the Neisseria gonorrhoeae or chlamydial trachomatis. Chlamydial trachomatis. This is high yield. That if there is sterile pyorrhea, that means pass negative, uh, pass in the urine, but no growth on the culture medium, that suggests urethritis by Neisseria gonorrhoeae or chlamydia trachomatis. Neisseria gonorrhoeae or chlamydia trachomatis. And the other thing you have to remember, another disease I would like to talk about, that RPN, that means renal papillary necrosis. This is the uh, complication of acute pyelonephritis. That acute pyelonephritis can convert into chronic pyelonephritis and renal papillary necrosis. In here there is gross hematuria and proteinuria. There is gross hematuria and proteinuria. There is gross hematuria and proteinuria, and the cause are SAT papa, sickle cell disease, acute pyelonephritis, analgesic diabetes. Sickle cell disease, acute pyelonephritis, analgesic diabetes, and papa is papillary necrosis. Papa is papillary necrosis. Papa is papillary necrosis. And the last thing I want to discuss, that the consequence of renal failure. The consequence of renal failure. You can remember by this mnemonic, that mad hunger, that means metabolic acidosis, A for metabolic acidosis, D for dyslipidemia, H for high potassium, and high phosphate. There is uremia, and the uremia, the clinical features of the uremia is nausea, anorexia, pericarditis, asterisk. Nausea, anorexia, pericarditis, asterisk, encephalopathy, and platelet dysfunction. There is sodium and water. There is sodium and water retention. There is growth retardation. There is erythropoietin failure, renal osteodystrophy.